Welcome back, Health Impact audience. We've had a great couple of sessions already, starting, of course, with how do you get rid of stupid things? And then in the last hour, we talked a lot about workforce and how it doesn't really matter how great your tech is or how great your strategy is, hybrid healthcare and all this other fancy stuff that we're talking about. We know that if your people aren't ready, it doesn't really matter. And so we covered a lot of that. And in the next 30 minutes or so, we have a jam-packed session with Michelle. I'm going to let her introduce herself in a second. But Michelle's over at Houston Methodist. And some of you know I grew up in Houston. And Houston is it's actually a very big healthcare town, easily rivaling or surpassing places like Boston and others. But it's not really well known from the outside as being as big as it is. So Houston Methodist is a big thing in Houston, which means it's going to be a big thing outside of other cities as well. And the reason why we wanted to have this conversation with Michelle is really to talk about what's happening on the ground if your innovation strategy pre-COVID happened to marry up and be rapid enough to be able to adapt to seeing COVID and the pandemic, not as a massive challenge that everything had to be thrown away, but looking at it as an accelerator, a true a way for us to be able to see, hey, were we making all the decisions properly over the last few years, and now we can kick them into higher gear and maybe make them happen faster? I mean, healthcare realistically still is very consensus-driven, very permissions-driven. But if your strategy for innovation was correct and you were doing proper innovation approaches, you should be able to kick those into high gear. And this session over the next 30 minutes is we're going to learn to see how Michelle and Houston Methodist were able to do that in many areas, and maybe even some areas where they've learned some hard lessons along the way. With that, let me introduce, let you introduce yourself, Michelle. Please let us know who you are and what you do at Houston Methodist.
Sure. Thank you so much. I really appreciate the opportunity here to speak with everyone today. Again, my name is Michelle Stansberry. I'm the Vice President of our Center for Innovation. I also hold dual titles. I'm Vice President of our Corporate Revenue Cycle Systems within IT. Houston Methodist, as you said, yes, it's pretty big here in Houston. We've got 7 different hospitals, a research institute, a physicians organization, so many multi-factor, health system to take care of our patients in the community.
Excellent. So let's start with this idea of radical resiliency in this hybrid healthcare world that HealthIMPACT is covering over the next couple of days. So when you think about radical resiliency, give us some stories about, what happened early on when you looked at your 2020 plans. How much of it did you get to keep and how much did you have to throw away? And what does 2021 and the road mapping around that look like going forward for you guys?
Sure. I think, for us here in Houston, March was just a pivotal change for us within, our organization and what we've been working on. Our process was really, what problems were we trying to solve within our institution? What pilots could we do to be able to help solve those problems? And then all of a sudden, March, we had our very first community spread patient with COVID, and it was all halt. We quickly gathered together, our Chief Innovation Officer gathered us in a room and was, okay, what have we got in place today that can really help us as we begin to ramp up and start taking care of this population of patients coming in? And it was multitude. It was, I will tell you, we were doing virtual health, not doing it, to the extent that everyone's doing it today. We had already been doing some chatbot functionality, doing some sort of, listening to the patients and so forth. But what we were quickly able to do was ramp up on virtual health, one, to get our physicians, because we had to close down all the clinics, right? So we quickly trained them to be able, within a very short time frame, to be able to see all of their patients. We had a virtual ICU project, was supposed to take 2 years. We did it within about 6 to 8 months to get up all of our hospitals, because again, we had to take care of this population that we couldn't always go into. The other thing, what was very important was, and I would tell you, we had kind of started this process, but think about the multitude of phone calls that were coming in from people just wanting to get information. We couldn't keep up. We couldn't keep up with over all those phone calls. And so we put in a chatbot functionality, which then really helped people get information they needed to. If they needed appointments, it would help, secure getting them through the route to get the patients, but then also be able to get to a true live person if they needed to. So all of this kind of really helped to just ramp up to be able to take care of this population in a way that we needed to. The other thing that I would tell you came into play on this was we had just kind of started down putting iPads into our patient rooms. And it was more from an entertainment perspective. We were just piloting it. Didn't have too many of them that were out, but wow, all of a sudden, here was an opportunity, right? We didn't want our staff necessarily always having to go into these patient rooms. Well, and also visitors couldn't come to these patients. So twofold, we were able to have the patients be able to have communications with the clinicians without necessarily going into those rooms, gowning on up in PPE and everything else. And also the patients were able to contact and stay in touch with their family members by way of these devices as well. So we quickly deployed them out to wherever we could to be able to help this. And it was kind of amazing results, what we saw from it. But those are just a few. I will tell you that, kind of ramped up. We've had a few other kind of lessons learned when vaccines hit us as well. And I can, kind of go into those a little bit. But, what I would tell you is we had so many things that were there as foundations for us that it didn't take us long to get ramped up and ready to take care of this population.
Yeah, and I think that's the really big learning lesson, especially for senior executives. If you're in the C-suite, the way that that your innovation team earned its keep is whether that team was thrown to the side or did they take center stage? Because the whole point of innovation is we don't know what's going to happen tomorrow, next year, the year after that, but we have to be prepared for the things that we don't know. And if this is a really easy way to find out, if it turns out, unlike Michelle, you and your team, if it turned out that the C-suite or the board went to the innovation team and said, we don't really need you during COVID, that was a useless innovation team, right? But if they said, holy cow, we got to double down, we have to figure out how to reuse everything that we're already doing, but now to dust off everything you saw over the last few years and see what we can accelerate faster and faster. And so I'd love for you to talk about two key areas there, which is innovation around your employees, applicants. What happened with those innovations? Did they accelerate or did they decelerate because of all the craziness that your employees had to go through? And the clinician burden reduction and all the other stuff that we've been talking about over the last few years, did that get accelerated or decelerated? So starting first from the workforce as a whole, and then narrowing down to the clinicians specifically, what did you guys do? What were some of the mistakes, myths, misconceptions that you can share with us?
Sure. Well, I would tell you, Houston Methodist, we have this concept that is probably at core of almost everything that we do, and that's this know me. Right? How do we know you as an employee, potential employee? How do we know you as a patient, your preferences, things that you like, what you dislike? How do we know you as a clinician, right? Again, on the same scale. So it's around this know me concept. And so when you take it back to the workforce, what's interesting is I know sometimes especially in technology, there's cool things in technology. But sometimes it's not always technology that solves everything. You always have to go back and kind of look at the process of what you're doing as well. Because as I said, we sometimes have this tendency to want to throw in technology on a bad process. So you kind of have to take them hand in hand to look at them. And when we really went and looked back at our applicant process, it wasn't always smooth. It was very burdensome, for the staff. And so we kind of did a few things, right? We kind of looked at the process and then we looked at the technology. And on the technology side, what we looked at was, this piece of, think about ordering a pizza. When you log in, it already knows you, kind of knows your preferences, everything else. We wanted kind of that same thing for our applicants when they came in. Very easy. if you want to apply for multiple positions, you weren't having to upload the same documents every single time. It kind of knew what your preferences, what are the things, what kind of clinicians are you looking more for, administrative or, in some other areas. So we really took that technology, and I will tell you, we kind of had to, because of vaccinations, not because of COVID, but because it was all hands on deck. And if you've heard a lot about vaccinations, we've done extremely well in that. But we kind of put it on the back burner for a little bit, and now it's really ramping back up, so that it is an easy way for individuals who are interested in Houston Methodist to be able to apply, and then also for our internal staff, it's an easy way for them to be able to go through that process as well. Mm-hmm. On the flip side of that, one of the things that we have done is we're really looking at voice, and how can we make not only this know me, but we truly believe that voice is the next wave to inherently make things run smoother, right? One is, I'll just tell you, for potential employees. One of the things that we did is we developed a skill set, everything around Amazon and Alexa's with the skill set. So the skill set is Houston Methodist, I'm interested in a job. So then it comes back off and it tells you, okay, here's what, Houston Methodist, and we focused in on clinicians at first, but it was a way that they could then send you that link, right? So that you could get all of the information about applying for a position at Houston Methodist. So all you had to do was speak about it at first. So that was kind of on the first side of, on staffing. But now let's go back on the internal side. And then the internal side was on our clinicians. And one of the things that I will tell you was extremely important for our CEO when he challenged us in innovation was EHRs have been great. They've been great for data. But I think if you ask your clinicians, it's really burdened them more on trying to, capture all of this data in the EHR. And so hence, like what we're doing, we're sitting and talking in front of a computer. That's what a clinician is doing. That's what a physician. So instead of them having face-to-face conversation with the patient, they're getting in front, trying to have a conversation with the patient, but looking at the computer most of the time. So what we've done, two things on voice right now, and we partnered with one of the kind of leading voice vendors, was with Amazon. And it was truly on a co-development opportunity with them and with another company called Parveda. So that our two projects is one in the ORs. So when our physicians and surgeons are in the ORs and they need to see patient data, so they want to look at the last labs, they want to look at the last PACS images, they need to start the case, they need to start tourniquet time, they stop the case, they want to input discharge orders. All they have to do is speak it. Now, our devices are named MIA, for Methodist Interactive Assistant. So it's MIA, start case. MIA, bring up last labs. MIA, bring up PACS images. So it doesn't have, so you don't have anyone in the OR having to physically be in front of the computer for them to get this information. So easy enough for not just physicians, but if you think of all the clinicians in the OR, they're not glued to the computer having to do this information, but it's very vital information that they need to not only input into the system, but get information out of it.
Are you getting any pushback on the voice? Remember voice, we used to call that dictation, but now it's actually real conversation. So the old days, it was one way, human to computer, barely understood. Now you've got conversation. So it must be
now it's interactive. Yes, it's very interactive. And I will tell you, we have had a lot of excitement over it. We're getting ready to pilot in two different places, one within a couple of ORs, and then we have what we call, it's an educational surgical suite, so that we will be able to have that in there. So not only does it educate, surgeons on different techniques, but it's also now going to be able to educate them on how to use voice, right, within our ORs, within Houston Methodist. So very exciting opportunity. And I will tell you, we've had a lot of excitement over it. And the number one reason is that it frees up clinicians from being tied to this computer.
Yeah.
The other is getting into ambient listening. And I know there's, other vendors out there that are doing ambient listening. But we saw a unique opportunity that it wasn't solving all of our problems. So we took it a step further by developing our own with this co-development, as I said, between Amazon, Parveda, and Houston Methodist. And so by doing that, not only now are we allowing our physicians to be able to have that normal conversational piece with their patients during clinic, right? But it's capturing diagnosis, it's capturing the notes of the physicians, it's also capturing what discharge orders are, what the discharge. It's also capturing coding, which is key, that then the physicians, all they have to do is go back in and make sure all the notes are correct, the problem is correct, the codes are correct, sign off, and it's done.
And so we used to call that charge capture apps, right? So now you're just doing charge capture via conversation. That seems very cool too.
Exactly. So, and then the exciting part about this is now we've built the foundation. So stop and think about, once you have the foundation in place with voice, where else can you take it? Stop and think about your nurses who are so overburdened with having to get all the kinds of different information from patients when they're meeting with them. So we're really looking at now, where is kind of the next wave of us to take voice? I will tell you, we're getting a lot of interest in across our organization, but we want to make sure that we're doing in the right places. Again, solving problems. Innovation could be really cool, but what I tell people is make sure that whatever you're doing is solving a problem for your institution. It may not be mine, but it's definitely yours. And so, we just want to take this in the right places and not just do it because, oh, well, this looks great.
No, it makes sense. And so some of the observations here are that you want hands off. So the conversations are very, very helpful. Another way to be hands off is through real-time location services. So RTLS, which of course has been around in hospitals for decades, if not longer. But what is especially about the RTLS that you find more appealing today than you've seen in the past? And how can you accelerate implementations of RTLS?
Well, and RTLS has been on our roadmap. It has, and we were looking at it really from a digital wayfinding perspective. And I will tell you, again, opportunity sort of, meets the problem that comes up at the moment. When COVID hit, we really saw that there was a need for a true touchless patient experience. So, and on top of that, vaccinations came on board. So, as any good organization would do, you kind of look at what's your tool set, what do you have, what can we use that we already are looking at. So we went out, we looked at vendors, not just in healthcare, right? RTLS has been around for long, but usually it was on medical device, managing wheelchairs and so forth. We wanted to use it for a different perspective, and that was more for our patients. And so we went outside of healthcare and looked at other vendors, had been doing venues, large venues. And so found a really good vendor within, intelligent locations. And lo and behold, not only what we were looking at doing from this process of scheduling your appointment with Houston Methodist, it then gives you directions from your home to the right garage, because as you know, Houston Methodist and the Texas Medical Center, multi-hospital, multi-garage, you could park in one garage that could be a mile away from where it is that your appointment is. And so it would go and bring you to the right garage. Then once you got into the garage, we wanted to be able to automatically check you in. So you've gone through that process. It then gives you directions to your exact location, walking directions. And then once you get finished with your appointment, it brings you right back to the garage where your parking spot is, because that's always a unique challenge here in this building. So it was taking this kind of foundation, what we looked at, and then sort of building on that, where we want to get to this true touchless patient experience, right? Barcodes, how much can you do on your phone here, with just coming in and walking through and paying things and so forth without having to sign a keypad, out having to take out a card and be able to pay for things. You can do it all on your phone. But the interesting part about this technology, what happened to us was when we started giving vaccinations, remember the temperature? I think that kind of threw everybody off. How are we going to keep these vaccinations at the temperature rating that they needed to? And especially when we were starting to look at hospitals, I think it was good. But when you start to give vaccinations, thinking from your PO clinics who only have refrigerators here, okay, you had to get in something else. This technology also allowed us to use the temperature monitoring from it, very real time. So it is, if it goes below a certain temperature, it's an automatic notification to somebody. If, there was a power outage, maybe at one clinic, it automatically notifies you that something's going on. Because lo and behold, we did not want to lose vaccines at all. That's a precious commodity to all of us these days. Yeah. So, we just found a different use case for it. And I think that's what, has been unique for us is not only did we have problems we were solving with the technology that we brought on, but we were also able to reutilize some of that technology to solve other problems that came up because of COVID and vaccinations.
Yeah, one thing that we haven't really dive deep on understanding is how much of all this touchless stuff is actually helping with general infection control at hospitals. Like pre-COVID, it was a massive problem to do understand, general infection control, sepsis, et cetera. And it would be great to try to get an understanding is that even though it wasn't for infection control, old style, the infection control that we were doing for COVID through the touchless experiences may actually help us going forward over the next 5 or 10 years to really get rid of some of the infection control problems that we've had in hospitals. So that's the kind of thinking that you want is use what you have now, what you had before, implement it quickly, but then try to open the aperture and see where it can go. So regarding that, and we're going to open the questions up in about 5 minutes to the audience, but I'd love, Michelle, for you to jump in. And a couple of other areas that you focused on is marketing and new patient acquisition, and really focusing around the patients and their caregivers. What I really liked about the first part of your story was it wasn't even just about the patient, but about the patient's experience. And the patient's primary experience with a hospital sometimes has nothing to do with the hospital. It's their caregivers and what they think about the hospital. Because if they're pissed, then the patient is pissed as well. So talk about the patient experience and those tools and technologies.
Oh, it's everything. And I could probably talk for days about this because I'm very passionate about it. But I want to get back to let's fundamentals. Fundamentals is what we had to really, and it was hard because when we installed our Epic, installation, we were like, oh, we're getting a great new patient portal. They're going to love it. They're going to love to be able to log in and get all of this. Well, you know what we found out? Patients hate to log into portals. They don't want to do it. So, when they have to schedule their appointments, they want to do everything. So I will tell you, the one thing that we have found, and we just kind of started off texting our patients as a reminder for their appointments, but it was bi-directional texting. So if I needed to reschedule it, I could just text back to that number. Either yes, I accept it, or no, can we reschedule it? So that was foundational. It was like, wow, we were getting all these emojis, how much they loved it, everything else. So how could we expand upon that? So now we're looking into how could we do text-based scheduling? Now, I know there's all okay, how are you going to do it from securely? How are you going to keep it, HIPAA compliant and everything else? But if you begin to think about the voice, what I said about with Amazon and the patient talking to, the Alexa device. Well, think about it at home. What if now I could, because now we've figured out how to do Amazon securely through Alexa. Now let's think about how it is, because I will tell you, we are now doing education, clinical education through another product, through the Alexa device. And it's on, different groups. But stop and think now about the patient. Alexa being able to say, I would like to schedule my appointment with Dr. whomever. So then it comes up securely, making sure that it's me. Michelle, please put in your code, whatever that's been texted to you. Okay, now that you can do that, then you can be able to start scheduling things through either text-based or voice-based, which allows them then to schedule their appointments or either get specific information. And then you start that journey in through us through Houston Methodist without necessarily having to just log into a portal, which, believe you me, like I said, we've got really good feedback. Patients hate to log into portals. So, the whole, and I'm going to use a term, and I think it's way overused these days, but I do believe in it. It really is about making an experience, no matter whom it is, workforce, clinicians, patients, making it as frictionless as possible, because that's how you gain the, you gain the patient's experience that they want from your institution, what allows them to keep coming back over and over and over again. And I think it's been proven, that all it takes is one bad experience for a patient to want to go elsewhere.
Yeah, and
That's
especially
not
in a place, yeah, especially in a place like the Texas Medical Center, where the next hospital is literally feet away, not miles away, but it could be in the next building. And this is the other challenge that you were talking about a few minutes ago, which is the reason why you guys have to care about the applicants and the staff and the workforce is that your competitor is literally, but it could be,
right
hundreds of
next
feet
door.
away. They're leaving, right?
Right next door. Yeah.
They're making it very portable, right? It's very easy to move between jobs. And so keeping your workforce, maintaining it, et cetera, very, very important. So in the last minute, if you could, what are some of the unique things that you guys have learned from this innovation strategy that you're taking forward now is, what did you learn that maybe caught you off guard, like the patient portal experiences, you spend millions of dollars building this stuff and nobody wants it, but we knew nobody liked portals from the beginning. It's not like there was a desire for even IT staff or innovators where they said, oh yeah, I love using portals, so I will use my Methodist portal. Even the people working at Methodist weren't using their Methodist portal. So that was a learning that we knew about before. We just didn't happen to do anything about it. But could we take some learnings like this to say, look, we can try new things much more rapidly. And is that the part of innovation that's really we're going to keep going forward is think less, do more? Or do we have to think more and do more?
No, well, I think it's a combination of both. And I really like the way that you put it. It is, it's not about thinking less, but again, I think it's a couple of things. One, remember the problem, right? Remember the problem you're trying to solve, and don't always think that it's technology that's going to solve that problem. But you also, and this is where sometimes health systems, they think too much. I will say, hey, we've got a process, and this process works extremely well for our organization, but it works horrible for the patient or the potential employee or the clinician. And that's where you have to take yourself out of things and make sure that you're trying to solve the problem for them. Make it easy for them, make it frictionless for them. And so for us, again, it was thinking outside of the box, going outside of healthcare to look for technology that would work for us. But it's also too admitting when something didn't work. And we've had those as well. We were trying to use an AI kind of model, predictive model to really, predict sort of the rush into our EDs. We had a product, we tried it, didn't work, and we scrapped it pretty immediately, but we learned from it. Mm-hmm. And now we've got another product that we're trying to bring in. So if there's anything that I could tell about innovation is you got to keep going. And that's one thing I was very appreciative about with our organization. We could have gotten very wrapped up in COVID and vaccinations to say, scrap innovation as a whole. No, it wasn't, because we had already had a really good foundation ahead of us, but keep going, but don't afraid to quickly go, doesn't work. Scrap it, move on. Because that's how you're going to quickly be able to reiterate and keep going with new technology and new process.
That's great observations, great advice. And with that, I'd love to open it up in the last few minutes for any questions that have come up. And questions have already come through the chat. I know we've handled some of those. But, and if you're open to it, of course, we'd love for people to be able to contact you for getting any advice, working together, et cetera. And I think Michelle is very open to that as well, I assume.
I am, very much.
Okay, great. With that, we'll open it up for the audience now. Welcome back, Michelle. So I thought we don't, unfortunately, we ran a little bit late on there. So I'll just ask you one quick question, and that is a combination between the point that you made in the chat about getting clinicians involved in the process. And one particular aspect I was interested in was the AI part of this. Have the clinicians that you're getting input from been afraid, neutral, not afraid, embracing about the AI topic in general?
They've been extremely interested in most advances in technology and innovation. I think the hardest part is dwindling it down to what can we do, because there's so many ideas on new ways and new things that we could be doing as an organization. And it's what I've said, you can kind of get caught up in all of the, stars, dazzle, whatever you want to call it. And, for us, for our innovation initiatives, they have to be solving problems for us to be able to do them. So, clinicians I have found, they are, most active and want to participate. We have tried to start up a physician-focused innovation group. We have a few others. One's in our clinical areas. One's in marketing, HR, revenue cycle. So we've kind of got really subgroups within our overall Center for Innovation. This is just another one. So you do have you may get clinicians who are not interested, but I will tell you, whenever you start to bring topics, and that's what you have to do. You can't just say, come to the meeting and bring ideas. But it's what I talked about in the chat with clinical remote monitoring. When we said that, wow, we had lots of opportunities where physicians wanted to come in and provide input on, this is what I need, which helps us to go try to find technology that would solve their problems.
Interesting. And were there any areas that you were trying to get attention from clinicians on that maybe you weren't getting as much input as you wanted?
Yeah, no, this just the key thing of what I wanted to say. When we very first started this, of trying to bring a physician innovation group together, and when you just do it with not really a focus to it, you kind of get a lot of ideas, but it goes all over the place. What we found works best is narrow it down. What is one thing you're trying to solve? Then you get really the input that you're looking for. If you come and just say, please come to the table, give us all your ideas, it's kind of all over the place. But again, narrowing it down to, okay, now if there's AI for radiology, if it's clinical remote monitoring, that's where you can really get the focus sessions and get some great ideas.
Awesome. No, that's a great advice. And sorry we ran out of time, Michelle, but this was excellent input. We'd love to have you on our next, both in person as well as remote sessions as well. And we'd love to hear from you again. Thanks again, Michelle.
Great. Thank you. Thank you, everyone.
And to the audience, please join us at the 2 p.m. session that is going to be starting any second now. Thanks, everyone. Bye.